institute appropriate treatment. And guys, I mean, this is where it's a make or break for people heading towards the exams. There's a reason that I'm going to talk about this. I'm talking about this once again, because today what we are going to do is we're going to give you, in addition to instituting appropriate treatment, we're going to be talking about recent advances. Guys, I cannot impress on you how important it is for you to not talk of the recent advances first without talking about the history and the clinical examination. So we're going to go through the entire gamut of pancreas. So without further ado, we'll go ahead and start. So we have a 52-year-old executive presents with a gradual painless development of yellowish discoloration of the eyes and skin with severe itching, more prominent at night over the last 2 months, and dark yellow urine. The stool has been pale in color recently, frothy and difficult to flush. Why do you think the stool has been pale in color and it's frothy and difficult to flush?
Increased fat content.
Very good. Excellent. Steatoria, absolutely. He has lost significant weight. The problem of using, I've purposely used the term significancy because the moment you talk about significant, it becomes over a 6-month period, because our definition of significant is that, you know, over a 6-month period, mild is about 5%, 5 to 10% is moderate, and over 10% is severe. So if you're going to give a history less than 6 months, some examiners make a big issue of using. So I am going to be very, very, careful of using this term, which is significant. So guys, can I just suggest one thing for you? If your weight loss doesn't last as long as 6 months, will you use the term substantive weight loss or any other? A profound weight loss, has lost a fair amount of weight, but don't use the term significant, because the moment you use the term significant, they're going to say you're describing a history of about a month. How can you justify, how can you, according to a definition of significant weight loss, you have to take the patient through 6 months? So guys, I mean, this is something that I would like you to bear in mind. And we'll go through all that in time. In the past 3 weeks, there has been pain in the upper abdomen radiating to the back, and recently there has been nausea as well. The patient is a heavy smoker and is fond of sitting with a few drinks with friends almost every evening. The patient has a type 2 diabetes mellitus for the past 6 years, nothing recent, and is a Kupuswami 28. We've been through the Kupuswami classification, you know that. But I'm going to ask you about this, about the patient being a heavy smoker. So how do you quantify heavy smoking? What is a pack year? How do you define a pack year? Anybody? Guys, I mean, this is vital. This is what gets you through the exam. What is a pack year? Okay, pack years.
Of cigarettes per year.
So it's important because I'm giving you the exact definition. Numbers of 20s pack, not 10s pack, 20s pack per day into years. Will you remember that, guys? This is something that you cannot afford to forget. So pack years is the number of 20s pack per day into number of years. So if a guy smokes 1 pack a day for 1 pack a day and has smoked for 10 years, he has 10 pack years. Okay? So remember, guys, that this is the definition of a pack year, number of packs per day into years. Right.
So normally they smoke just 4 to 5 cigarettes a day.
Yeah, so you can't really, so what you need to do is, let's suppose he smokes 10 cigarettes a day. So that's half a pack. Half a pack into half a pack per day into 10 years makes it a 5 pack years. Get it? If he smokes 1/3, let's say he smokes 6, you said. So 6 to 7 is approximately 1/3. So it's going to be 10 divided by 3, isn't it? So it's going to be 3.3 pack years, isn't it? Get it? So the unit is 20 SPAC. I had a doubt and I referred back to all the data, and I'm giving you the one that actually came through all the papers that are there on pack years. Okay. Right, guys. So you also have a recent onset, unexplained upper abdominal and thoracolumbar back pain accompanied by the normal GI investigations. So if you have any of these, pancreatic cancer should always be entertained and appropriately investigated. So recent onset, unexplained upper abdominal or thoracolumbar back pain accompanied by normal GI investigations, extrahepatic obstructive jaundice, unexplained weight loss of more than 10%, unexplained acute pancreatitis after the age of 50, unexplained sudden onset of diabetes after the age of 50 years, without, particularly if the patient doesn't have a family history, is not obese, and hasn't been on steroids. So, in the clinic,
smoking, can we use a smoking index?
Yes, you can use the smoking index, but the accepted thing is to use a pack here. You can use the smoking index so long as you know the definition. So what is the definition of a smoking index?
Number of cigarettes smoked per day into years, number of years of smoking.
Yeah. Yeah. So it's approximately a derivative of pack years, isn't it?
Yes, yes.
Okay, get it? There are various ways you can define it. So long as you have the definition right, it's all right. Of course, you can use a smoking index. If you have the definition right, so be it. Okay. So, clinical scenario. The patient has icterus, scratch marks over the trunk, and shiny nails. Shiny nails, you know, because he's been itching all along. So the nails get shiny. He is dehydrated with features of weight loss. You know, profound features of weight loss. Virtuous lymph nodes palpable. Smooth, non-tender pyriform swelling in the upper right abdomen quadrant, moving up and down with respiration. It is continuous with the liver. There's no free fluid. Rectal examination is normal. Right. So, guys, I want you to tell me what do you know about bilirubin metabolism. Guys, just think about bilirubin metabolism. I'm going to get my pen because I had to rush from my laptop, which wasn't working, to my desktop. I'm just going to get my writing pad. Just a sec. Give me just half a minute. Sorry about that, guys. I'm back. I believe I'm on Airtel broadband now. Apparently, the Geo connection has been acting up since morning. So there we are. Now we know. So, guys, bilirubin metabolism. Go on. RBC, if you consider it a batsman, it does scores exactly 120 runs. So after 120 days, it goes into the spleen, back to the pavilion, where it takes off its pad. And so what happens? You tell me. Right. So hemoglobin is a tetrapyrrole ring. It has iron on it. So the iron, heme and iron gets separated. The iron comes out as a ferrous form. Ferrous form, guys, is very toxic. So it has to go through the cells in the spleen, where ceruloplasmin transforms it into ferric, gives it a ferric form, to which, because it becomes ferric, it is transferred with transferrin to the bone marrow, where it again gets into the circle of erythropoiesis. Now heme is acted on by heme oxygenase and forms the green colored biliverdin. Remember that the Latin for green is verde, V-E-R-D. Verde is Latin for green. So biliverdin is green, and then to bilirubin. Now bilirubin itself, this, remember, is unconjugated bilirubin. It's toxic. So how is it transferred from the spleen to the liver?
With albumin.
Very good. Excellent. So the albumin goes and transfers it to the liver. Now, at that point, it is unconjugated bilirubin. Now, sometimes you have genetic defects at this point, because there's an organic anion transport, OAT protein, which sometimes is deficient. So guys, what are the genetic conditions? Gilbert's and Crigler-Najjar syndrome. Crigler-Najjar syndrome is two forms, can be one, which is where the OATP protein is absent, and these are children who don't survive. They have connectors and they die. But Crigler-Najjar 2, where the OATP protein works slightly, in these kids, the bilirubin is more severe than Gilbert's, but still the kids survive. And Gilbert's, as you all know, is a clinical condition where you have elevated unconjugated bilirubin, but not too much of deficiency. Right. So now in the hepatocytes, the unconjugated bilirubin is conjugated. It's conjugated twice. So now you have conjugated bilirubin. You also have genetic defects in conjugated bilirubin being excreted into the bile canaliculi. And that condition is called a Dubin-Johnson or a Rotor syndrome. Having been excreted, what happens is the bilirubin, the conjugated bilirubin, goes into the intestine, then travels all the way through the intestine to the terminal ileum, where it's acted on by bacterial glucuronidases to form stercobilirubin and stercobilin and urobilin. They form the pre-existing form called stercobilinogen and urobilinogen. Both of these are colorless. It's only when they become stercobilin, it gives stool its orange color. And we'll come to that later. So stool its orange color. And a bit that is reabsorbed gets excreted. 5% of that, that's why it's a smaller shadow. It gets excreted, gets carried in blood to the kidneys, where it gets excreted. And on standing, urobilinogen transforms to urobilin. And then your urine becomes slightly darker in color. So guys, that is the entire bilirubin metabolism. You have to have this completely. I mean, it doesn't matter if you don't know the last bits that I'm going to tell you in class today, but this is something that is absolutely must. And therefore, these are the types of jaundice. Guys, take a screenshot of this. Types of bilirubin can be prehepatic, hepatic, and posthepatic. Types of bilirubin elevated is an unconjugated bilirubin. Both in hepatic, both conjugated and unconjugated bilirubin. And a post-hepatic, it is conjugated bilirubin. And you know that we call the conjugated bilirubin direct. And you know why we call it direct, because there's a diazo based test called the Vandenberg test, where because the direct bilirubin being conjugated is soluble in water, it tests immediately. But what you need to do is to calculate the total bilirubin. You have to calculate the total bilirubin, and the way to calculate the total bilirubin is to dissolve the total bilirubin in alcohol. So ETOH. No, I think this I wouldn't be able to write today. And once you do that, you get total bilirubin. The way to get unconjugated bilirubin is to get the total bilirubin and subtract the direct bilirubin from that. Direct bilirubin. And what you get is the indirect bilirubin. This is why, because you need to do a subtraction to get it, that is why indirect unconjugated is called indirect and conjugated is called direct. Guys, remember that. I mean, you've already had a class on this, I think, I believe. Right. So in urine, what is thrown out? In prehepatic, conjugated bilirubin is absent. Urobilinogen is hugely present, and bile salt is absent. In a posthepatic, conjugated bilirubin is present. Urobilinogen is not present, and bile salts are also present. As a result of which, in hepatic, you have a biphasic. You have an early stage and a late stage. In an early stage, it is more hepatic, almost like a prehepatic. In a late stage, it is almost post-hepatic because the cells get larger and the biliary canaliculi get blocked. So you initially have a high amount of unconjugated bilirubin. Then at the later stage, you have conjugated bilirubin. So you have, it's called biphasic. The urine color in a post-hepatic, because you have directly conjugated bilirubin being produced, it's dark because there are bile pigments and salts. In a hepatic, dark because both are present. Now, urine color, you remember what I said. I mean, if you have urobilinogen, it is colorless. But if you keep those, sometimes some person with, huge amount of hemolytic jaundice, you keep that urine standing. If it stands for a bit of time, it automatically becomes from urobilinogen, becomes urobilin, and then can be deep yellow in color. The stool, it is no-brainer, normal to dark in a prehepatic and hepatic, and pale in a posthepatic. Pruritus absent in both the prehepatic and absent or mild in a hepatic, and it's pronounced in a posthepatic. And the usual question sometimes asked is, why does it itch? Who's going to tell me why does it itch?
Nerve terminals get irritated.
Yep, the free nerve endings and the subcutaneous tissue gets irritated. Now, there's another question that is often asked by a number of examiners. Why is itching more prominent at night?
Gateway theory.
Yep, absolutely. So just amplify on that. If it is carried on by the posterior fibers, and on the way into the spinal cord, there's a gate. And when you have other impulses coming in, not so much of impulses go through. So because your extraneous impulses are less during the daytime, during night, itching is more. So there are two pathways that carry it to the corticothalamic tract. One is a normal pathway. The other is called a Cowhage, C-O-W-H-A-G. I wish I could have written it up, but my pen, it's called the Cowhage. Let's see. Cowhage. Remember that is the pathway that carries all the impulses of pruritus. So the Cowhage pathway. Right. So we come to the next phase. How is nutrition assessed? So how is nutrition test? The four things that you have to remember during an examination is this: BMI, the triceps skin fold thickness, the mid-arm circumference. So BMI assesses the body weight as a proportion, as an expression against the height. The triceps skin fold thickness assesses the skin fold of the fat. Mid-arm circumference assesses the thickness of the muscle, and of course, vitamin deficiency. So, weight loss. Remember, I told you, whenever you talk about a significant weight loss, it's over 6 months. and it's mild means less than 5%, moderate is 5 to 10, and severe is more than 10%. So again, guys, if you have symptoms, if you're describing a patient with symptoms less than 6 months, please don't use the term significant, okay? Some people are very sensitive, so some of your examiners are very sensitive. So you say that it's lost so much amount of weight over a period of a month or over a period of 1 or 6 weeks. And let them ask you what is significant weight loss, and then you can come out with this definition. BMI is weight in kgs over height in meters square, or you could have weight in pounds into 703 in over height in inches square. So that's your BMI. But there's another thing. BMI for the Asia Pacific cohort is quite separate from the Caucasian. So less than 18.5 is underweight, 18.5 to 22.9 is normal, 23 to 24.9 is overweight, and over 25 is obese. So remember, guys, that this is something that you will need to remember. You need to remember that. Okay. So these are things that you have to remember. Okay. Skin fold thickness. Now, skin fold thickness, I'm going to give you an extensive. For you, it's the triceps skin fold thickness. But sometimes you need to know something else. And what do you need to know? Triceps is midway between the acromion and the olecranon, with the arm held by the side. It's not at right angles. Subscapular, diagonal fold, 45 degrees, 1 to 2 centimeters below the inferior angle. Okay. You also have the chest and pectoral, which is different for men and women. In men, it is halfway between the anterior axillary line and the nipple, and in women, 1/3 of the way from the anterior axillary line to the nipple. And abdomen is a vertical skin fold 2 centimeters to the right of the umbilicus. Okay. You also have a suprailiac, which is a diagonal fold, natural angle of the iliac crest just superior to the anterior axillary line, and a thigh is a vertical fold on the anterior midline of the thigh, midway between the proximal border of the patella and the inguinal crease. Now you ask me, why do we need to know all that? Isn't it sufficient to know the triceps? No, the only difference is that when you're assessing percentage of body fat, then these formulas come in. There are formulas for both men and women for body density and percentage, and the body density is used to measure the percentage of body fat. There isn't a very complicated formula. But then in women, what is assessed is the triceps, the suprailiac, and the thigh for women, and the chest, the abdominal, and thigh for men. So that is when you're assessing body density, all these other skin fold thicknesses are used. Right. You also need to assess muscle wasting, and we do that by taking the circumference, mid-arm circumference, to assess the bulk of muscle at the arm. But it's measured with a measuring tape, and this is measured after positioning. It's perpendicular to the length of the arm at the marked location. The arm has to be flexed 90 degrees at the elbow. So remember, for the triceps, the arm is held by the side, and in a measurement of the muscle, the arm is flexed 90 degrees at the elbow in a supinated position, and it's measured midway between the acromial point and the olecranon point. So you take a circumference, mark that point, and you take the circumference out there. But other areas, temple, the clavicle, the shoulder, the scapula and ribs, the quadriceps, the interosseous muscle, particularly the dorsal part of the thenar area, where you often find a gap if there's muscle loss. The functional tests are also important. You do a grip strength using a dynamometer and rising from the chair. So if you're going in for major surgery, some papers actually assess muscle strength, and sometimes you have an expression of post-op morbidity as an expression of body weight loss. Right. The other way to assess the muscle is you have a gradation of functional test, and this is known as the Oxford scale. So starting off with the worst, you have a flicker of movement, 2 is through full range activity with gravity counterbalance, which means you're not working against gravity, which means if, for example, you're flexing and extending the knee, you turn the patient on the side and the patient is flexing and extending the knee at right angles to the gravity, so it doesn't work. 3 is through full range actively against gravity. 4 is through full range actively against some resistance, and 5 is through full range actively against strong resistance. So that's the Oxford scale. But we also have a CT scan and image-based assessment. And for image-based assessment, if you can use a CT scan, you can use a cross-sectional area of the psoas muscle at the level of the third lumbar vertebra, and it is measured by computed tomography and normalized by the square of the height to calculate what is something called as the psoas muscle index. So it's centimeters square by meter square. And so that is the size, that is the actual size of the psoas. And you divide that by the square of the height in meters. So it's normally 3.74 centimeters per centimeter square by meter square for males and 22.29 centimeters square by meter square for female individuals. Right. Now, this was a trial from Chennai, and they tried an excellent thing, standardizing the Indian values. But then, guys, I would be slightly worried because the values that they calculated weren't really correct. I calculated the values and it wasn't really right. So just be a bit cautious about using this. This was from the Sri Ramchandra Medical College in Chennai. And while the attempt was excellent because you had a complete standardization between all the ages, the calculation is not really correct. So I would be a bit cautious of using that. Of course, you have vitamin deficiency, vitamin B, riboflavin, you have chylosis and angular chylosis and other changes are associated with the lips. Vitamin C, you have vitamin C, scurvy. You have changes in the gums and you have hair follicles. The follicle have a corkscrew lesions in all hair follicles. Vitamin A is night blindness, and vitamin B3 deficiency, you have pellagra, and you can see that this is the pellagra skin of a person with severe vitamin B3 deficiency. Right, guys. So now we land up with general survey and we found the left supraclavicular node on examination of the neck. That's the supraclavicular node. So guys, what is the name of this node?
Virtuous.
Very good. Excellent. But remember that some of your examiners have in their stock other signs. So it's sometimes called the sentinel node, sometimes called the Troisier sign. Okay. And why does it spread out there? From a pancreas, why should it spread out there? What is the root?
Thoracic duct.
Okay, thoracic duct. Cisterna chyli. Yes, cisterna chyli travels up through the chest and crosses over on the right side initially, crosses over to the left at about the fourth vertebra, approximately, enters into the thoracic duct, which enters where? At the junction between the left subclavian and the left internal jugular vein, isn't it? Right. So, this gentleman was Virchow. He was a German doctor, an anthropologist, a pathologist, a historian, a biologist, and politician known for his advancement of public health. The reason I asked you this, do you have any idea how many things he described and he lent his names to? Any idea? I'm sure you know another one, absolutely. Virchow's nodes we know. We know something else.
Virchow triad.
Virchow triad. Very good. Excellent. So we know two. Please, guys, again, as I said, when you're starting off with the clinics, remember these two. But just as a matter of interest, he actually named 14. Okay? Of which, remember Virchow's gland and remember Virchow's triad. but he actually went to town. He actually named 14 things. So I'm not even going to spend time on that. Right. Now, virtuous nodes. Which node station is it? What are the node stations of the neck?
Level 5.
Level 4.
5.
It's 5 it's where is it situated? It's situated here, isn't it? It's a lower deep cervical lymph node. The virtuous gland is a lower deep cervical. It's not 5. We traditionally describe it as a supraclavicular. It is not the supraclavicular. 1, 2, 3, 4. So we are actually talking of 4. Supraclavicular lymph node, though we call it a supraclavicular lymph node, the classic virtuous node is actually situated in station 4. Guys, always remember that. Okay. Right. Now this patient now comes in with this CT scan. What do you think has happened?
Gastric CA.
Not gastric CA. He had a pancreatic, he has a pancreatic cancer, which spread to the virtuous lymph node. But then he had this. What do you think is being shown out here? Pity that I don't have my pen properly, but I'll try. See, guys, that's the cupola of the right diaphragm. That's the cupola of the left diaphragm. So what do you think has happened? Come on, guys. Virtuous node. What do you think has happened? See, that's the virtuous node. It sits on something very important that goes just behind it.
Pancreatic cirrhosis.
No, it's not. The virtuous lymph node sits on this. What is this, guys? It comes from, hang on, it comes from
Phrenic nerve.
phrenic nerve. Absolutely right. 2, 3, and 4. Okay? So that's the phrenic nerve going down from here. Right. So that's the, it also has other little ansa cervicalis branches, and much more important is it has something else behind it. It's the posterior relationship of the virtuous node. Hang on, let me get it. Yep. My drawing isn't going to be best, guys, because my pen doesn't work well with my desktop, but there we are. So that's the transverse cervical artery. That's a transverse cervical artery. And that is your left phrenic nerve. So guys, what do you think has happened out here?
Palsy.
Palsy, absolutely right. So guys, I want you to remember this throughout, because if you're ever asked what is the posterior, what is the relationship of the virtuous lymph node, it sits bang in, hang on, let me just get that anatomy completely right. It sits bang at the junction that is, no, I can't. It sits bang at the junction, that's the internal jugular, that's the subclavian. The thoracic duct drains in out here, then it gets blocked, as a result of which you have reverse flow, and because you have a reverse flow, lymph nodes, metastatic cells sit out there, but it lies on top of the scalenus anticus muscle, which lies behind. Okay, and on top of that, it lies on top of the left phrenic nerve and the transverse cervical artery. So guys, remember, that's the anatomy of your virtuous lymph node. And if you ever have something like that with a virtuous lymph node, almost certainly think of a left phrenic nerve palsy, causing the stomach, the kidney, and everything to go up. Okay. Right. So, symptoms. These are the symptoms of cancer of the pancreas. Asthenia, 86%, weight loss, 85%, anorexia, 83%, abdominal pain. And that's the reason I spent such a lot of time on nutrition, guys. Epigastric pain in 71%, dark urine in 59%, jaundice in 56%, nausea 51%, back pain 49%, diarrhea 44%, vomiting 33, steatorrhea and 25, and migrating thrombophlebitis. That also has a name. What is the name? Yep, right. And skin lesions. Sometimes you have skin lesions. Almost looks like saponification, but they are not. It's called a paraneoplastic. It's a part of the paraneoplastic syndromes in a pancreas. You have jaundice in 55, hepatomegaly in 39, a right upper quadrant mass in 15, cachexia in 13, and of course the famous Courvoisier's law in only 13%, and an epigastric mass in 9. And of course, you can have ascites. So what are the differential diagnoses? Guys, take a screenshot of this. Cystic lesions can be non-neoplastic, true cyst, pseudocyst, retention cyst, and cystic lesions. It can also be a parasitic lesions. I've had a patient who had a pancreatic hydatid, and you might have seen that picture in Bailey and Love. It's there. Was explored, and we found that it was actually a hydatid cyst. We thought it would be a cystic neoplasm. It wasn't. Of the neoplastic cyst, you have a serous cyst, you have mucinous cyst, you have solid pseudopapillary neoplasms, that's called SPNs, and intrapancreatic mucinous neoplasm. So we are going to discuss this entire section in the next class because it's a whole new class. Of the solid lesions, you have non-neoplastic, you have inflammatory, and you even have tuberculosis. I was badly caught out on one. The young girl was an executive, came in with a large mass in the hair of the pancreas, and guess what? Was ultimately a biopsy, had caseous material on exploration. We sent off a biopsy, it was tuberculosis, and she was home and dry after a prolonged course of anti-tuberculosis therapy. Neoplastic, you have a pancreatic exocrine tumor. That is the nomenclature for neoplastic tumors. You also have a pancreatic neuroendocrine tumor, and of course, you have lymphomas. So what are the investigations? You do a blood investigation of a complete blood count, your electrolytes, a liver function test, a prothrombin. Time is a must, because these patients are jaundice and they often have coagulopathy. CA19-9, though it's really sometimes with an obstructive jaundice for some other cause, you also have a very high CA19-9. If you suspect a neuroendocrine tumor, serum chromogranin A, if you're suspecting lymphomas and LDH and a beta-2 microglobulin. And preliminarily, you have an ultrasound scan to assess for a mass in the pancreas and the status of the CVD and evidence of distant metastases. If you've got a distant metastases, your entire approach changes. If you don't have a distant metastases, then you would go in for a triphasic CT scan with a pancreatic protocol, multi-detector and helical, or an MRI and sometimes in addition an MRI with an MRCP. Some people would go in for an ERCP with biopsy. If you look at periampullary lesions, if you consider periampullary lesion, and if you have a head lesion which is amenable to FNAC from an endoscopic ultrasound, you might even actually do that, an EUS with an FNAC. In a triphasic CT scan, the total amount of contrast differs. There are many protocols. A standard dose is given related to the weight of the patient. If the weight is less than 75 kilograms, 100 cc is given. 75 to 90, 120. And if the weight is more than 90, you give 150. A maximum dose of 150 is given when one is looking for pancreatic carcinoma or liver metastases. Always remember that a pancreatic carcinoma has arterial supply. It doesn't have a portal venous drainage. So that's how it's. So what is done is, in addition to 5 millimeter sections, what is followed in the pancreatic protocol is at taking the pictures at different times, non-enhanced CT, any CT, helpful in detecting calcifications, fat in tumors, fat stranding as seen in inflammation like appendicitis, diverticulitis, or mental infarction. So you have very similar sort of, can have inflammation, and that actually tells you it is likely to be a pancreatitis rather than a pancreatic neoplasm. But if you have a fat, that is suggestive of a tumor. Early arterial phase, which is taken 15 to 20 seconds post-injection. And this phase when the contrast is still in the arteries and not enhanced the organs and other soft tissues. You have a late arterial phase at 35 to 40 seconds post-injection. It's also called the arterial phase or the early venous portal phase because some enhancement of the portal vein can be seen. All structures that get their blood supply of arteries will show optimal enhancement, which is why you search for this during your pancreatic phase protocol of doing a triphasic CT scan. A hepatic or a late portal phase is at 70 to 80 seconds post-injection. Hepatic phase is the most accurate term. Most people use the term late portal phase. In this phase, the liver parenchyma enhances through blood supply by the portal vein, and you should see some enhancement of the hepatic veins. A nephrogenic phase, by which time the dye has moved into the kidneys, when all that's at 100 seconds post-injection, when all of the renal parenchyma, including the medulla, enhances. Only in this phase you will be able to detect small renal cell carcinomas. And sometimes you have a delayed phase of 6 to 10 minutes post-injection. It's also called a washout phase or equilibrium phase. The washout of contrast in all abdominal structures except for fibrotic tissues, because fibrotic tissues has a poor late wash. It doesn't have a lot of blood supply, so it becomes relatively dense compared to normal tissue. So this is perfect for picking up scars in tumors, and we'll talk about that when we are doing the cystic lesions. Particularly, it's almost comparable to late enhancement of infarcted scar tissue in cardiac MRI. Okay, guys. Now, somebody needs to tell me, I've been talking for quite some time now, tell me what does it show? This patient presented with obstructive jaundice, painless, progressive obstructive jaundice. So if we see that, let me first ask, what is this? This one, right? That's the kidneys. Okay. That's the aorta. The only way you can see the IVC is that it's just the right renal vein coming into the IVC. Okay. And it is taken at a phase where it's very difficult to be sure, but we presume that that is the splenic. Now, if I show it to you closely, very up close, now you tell me what you see. Hang on, let me just come in. Let me just come in for a while. Right. So that is your common bile. This is a common bile duct. Okay. This is, I'm sorry guys, I'm going to be a bit of a mess today. I promise next time we won't. That is the duodenum. Okay. If that's the duodenum, there's something else out here. Have a look. In the late phase, what did I say? In the late phase, tumors become hypodense. So now have a look at something that I want to show you. Can you see that bit? So that is your tumor. Can you see that, guys? And if you really see, that is the IVC, so it's far away from the IVC. That's the IVC. That's the IVC. It's far away from, very far away from the SMA. Very far away from the SMA. The portal vein cannot be seen because it's all, you know, it's at a phase where it can't be seen, but we presume it's somewhere out here. So this is fairly far away. This is obviously a resectable tumor, a resectable periampullary tumor. And periampullary, as you know, are all lesions which lie within a certain 3 centimeter radius of the ampulla. It can be a actual true periampullary lesion. It can be a carcinoma of the head of the pancreas, can be a cholangiocarcinoma at the lower end as well.
Sir, how aorta and IVC both are seen?
Sorry?
How aorta is also with contrast and IVC is also with contrast in the same place. How it will happen?
Well, IVC is this one. This is the IVC.
So contrast will be, how it will be at the same time in the both of the things. Aorta also on IVC.
It's taken at a late phase. It might be that a bit more of contrast, but you know, if you look at the pancreas, can you see how white it is?
Yes,
so
sir.
we think at that phase, they might have given a bit more of dye to identify this particular structure. They wanted to throw this into relief. Otherwise, you're quite right. You shouldn't have seen, you know, that's the aorta. And you shouldn't be seeing so much dye in the IVC at the same time. You can see, but it's not so bright. I grant you that, absolutely. But the moment you see that it's reached there, you see the character of the pancreas out here, and you see the character of the kidney. It's almost the same. That shouldn't have happened, isn't it?
Yes, yes.
So we think that just to make sure you identify that there's a portal washout, you know, not a portal washout. The portal vein, it doesn't have a portal phase. A tumor, pancreatic tumors are characteristic in that they don't have any portal supply. So you can see that that is an irregular lesion. Can you see that?
Yes, sir, yes.
Okay, right.
Thank you, sir.
Another one. What do you think out here? As you can see, you can still see the dye in the IVC and the aorta. That's a superior mesenteric. That is the portal vein. And you can see that the tumor is actually, I'm a bit scared of drawing this pen, but you can see that the tumor is this. Quite a large tumor, isn't it? And see how much it has encased the superior mesenteric artery. And it has infiltrated into the stomach. Can you see the stomach being infiltrated out here? There's not much. This is the muscle. You can see that the stomach is infiltrated. Okay? And you can see that the duodenum is also flattened. So this is a fairly advanced carcinoma of the pancreas.
GB is also distended, sir.
Yes, GB is also distended. Absolutely. So that, you know, for a change, you have the Courvoisier's law working out here, isn't it?
Yes, sir, yes.
Okay. Next one. MRIs can also give you a picture, and you can see that in an MRI, because of the fat content that you sometimes in T2 weighted image, that is the tumor out here. You can see that again, this is Courvoisier's law being proved, but you can see that that is the actual lesion, which is, can you see it is slightly whiter than the rest of the lesions? Can you see that area?
But so why pancreatic duct is not visible?
In this slice, because it's a reconstruction. MRCP is a 3D reconstruction, isn't it? If you haven't taken it at the appropriate angle, the pancreatic duct won't be visible.
Okay.
You can rotate it around, isn't it? You go to the MRCP console, what do? They rotate it around. In this particular rotation, what they've done is they've rotated to a point that you can actually see the tumor well. So that is the tumor. Can you see the tumor now?
Yes, yes.
At content. Right. Next one is this. Now you see that this is a patient with a cystic neoplasm at the tail of the pancreas. And you can see that this is the lesion out here. And there's a bit of a spread behind. I want you to remember this when we are going far into its surgical. I'll be sharing this picture once again when we do the surgery out here. So there's a role of FDG PET also. It's sometimes asked. It actually lacks a high resolution anatomy. So it's twinned with a CT scan. So the first integrated PET CT was done in 1998, so not very long ago. For better detection of metastases, the pooled sensitivity 91% at the detection of peritoneal metastases, 91% for primary pancreatic lesions, 85% for local regional staging, and 92% for restaging of pancreatic cancer after a neoadjuvant treatment. But there are some disadvantages. A small tumor characteristic, a small lesion size, ampullary carcinoma, a necrotic tumor, a cancer with a low metabolic activity, like a mucinous adenocarcinoma or a neuroendocrine tumor, can cause false negative results. If you have diabetes, after you're using FDG PET, you're using glucose. So hyperglycemic status, which is often seen in patients with pancreatic pathology, may also lead to a decrease in the absorption of FDG due to competitive inhibition. Benign conditions, several benign conditions, and we've often been caught out, such as post-operative changes, inflammation, acute pancreatitis, infection abscess, and an adjacent bowel activity of physiologic origin or induced by diabetic medication can mimic malignancies. And sometimes there are some technological problems, technical flaws, such as motion artifacts. You sometimes have something called a misregistration and an attenuation correction error related to surgical clips and staples. They could cause misinterpretation.
Diabetic sensitivity decreases of PET.
Yes, because you have competitive inhibition for that site, FDG and diabetes. If it's a poorly controlled, which is why if you have a poorly controlled diabetic, they won't carry out an FDG PET. But the future, 18F-fluoro-L-thymidine, a marker for cell proliferation, where you don't use glucose, and a 68 gallium-labeled somatostatin analog, peptides with high affinity for neuroendocrine tumors, are the way forward for a PET. Okay. Now, this is a PET scan of a colleague of mine. He's a pediatrician. And being a pediatrician, he was a smoker. And being a smoker, he as a doctor, he insisted on having a PET scan every year because there was some suspicious lesion in his lungs. So rather than stop smoking, he did PET scan. And guess what? One of his PET scans shows this. What do you think is being shown?
Bladder tumor.
No, bladder collects the PET, it's by process of excretion. The two regions you will not comment on is the brain, the kidneys, and the bladder. Okay. But look at this lesion. Can you see that lesion? Okay. That lesion. Can you see that? That was a lesion in the duodenum. So we did an endoscopic biopsy and it was a highly dysplastic tubular villus adenoma. was the diagnosis, perhaps even with in situ carcinoma. Okay, right. So you see this? That's the lesion. And you see this? That's the lesion. But there's something that even this missed. Something that this missed. And what this missed was this thing. It was staring at us in the face. Can you see that? That's a kidney tumor. Can you see that? And this is a PET negative kidney tumor. So
it is there in last side.
Sorry?
And down there it is showing some sparking kidney also.
Yeah. The last one, it's just about faint, it's not showing up as high as this. The rest of the kidney, I told you, the FDG PET gets excreted by the kidneys. So, which is why the urinary bladder comes as a hot spot. You've seen how hot it was.
Yes.
That's how hot it was, hot spot. But now you can see that we actually overlooked that tumor.
Mm-hmm.
Right. So that's the tumor. But we had a very good radiologist who actually commented. So this gentleman underwent a Whipple's with a right radical nephrectomy. That was about 9 years ago. Thank God he had a stage 1 kidney tumor. And ultimately it was proved that he had a very, very dysplastic tubular-villous adenoma of the duodenum. With in situ cancer. So he's doing well. He's off smoking. So that's great. So pancreatic cancer, the etiology: smoking, diet rich in animal fats and alcohol, coffee, chronic pancreatitis, diabetes mellitus, gastric resection, genetic influence, and possible role of virus infection. So what are the benign epithelial tumors and precursors? This is the WHO 2019 classification. Serous cyst adenoma, you want to take a screenshot of this and the next slide, you can, next 2 slides. So serous cyst adenoma, macrocytic, oligocystic serous cyst adenoma. You can have a solid serous adenoma, a von Hippel-Lindau with associated serous cystic neoplasms, and a mixed serous neuroendocrine neoplasm. You can, of course, have a serous cystadenocarcinoma. The other group is a glandular intraepithelial neoplasm, can be low grade or a high grade. You have an intraduct papillary mucinous neoplasm, which can be intraepithelial or again low grade or high grade or even invasive. You can have an intraduct oncocytic papillary neoplasm, not otherwise specified or invasive. You can have an intraduct tubulopapillary neoplasm without invasion and with invasion. You can have a mucinous cystic neoplasm with intraepithelial neoplasia, can be a low grade, a high grade, or an invasive. This is the WHO classification of 2019. And finally, you can have ductal adenocarcinomas, not otherwise specified, and you have this whole gamut of colloid, poorly cohesive, signet ring cell, medullary, adenosquamous, epidermoid, large cell carcinoma with rhabdoid phenotype, undifferentiated carcinoma with osteoclast-like giant cells. These are the ductal adenocarcinomas, and you have acinar cell carcinomas, can be a cyst adenocarcinoma, a mixed acinar neuroendocrine, a mixed acinar endocrine ductal, or a mixed acinar ductal. You can have, particularly in the young, a pancreatoblastoma. You can have a solid pseudopapillary neoplasms either with a low grade or a high grade dysplasia. Of course, you can have the pancreatic neuroendocrine group, microadenoma, and I think Dr. Ramanuj Mukherjee has taken you through that. You can have the pancreatic neuroendocrine tumor, which is grade 1, grade 2, and grade 3. Or you can have a pancreatic neuroendocrine tumor, which is non-functioning, oncocytic, pleomorphic, clear cells, or cystic. You can have a pancreatic neuroendocrine tumor, which is functioning, And of the functioning, you have an insuloma, you can have a gastrinoma, vipoma, glucagonoma, a somatostatinoma, an ACTH tumor, an endochromaffin tumor, or a serotonin-releasing tumor. You can have a neuroendocrine carcinoma, can be a small cell or a large cell. But the other funny tumor you have is sometimes a mixed neuroendocrine and non-neuroendocrine neoplasm called MENIN. Can have a mixed acina endocrine, mixed acina neuroendocrine, or a mixed acina endocrine ductal. So this is the WHO 2019, and I think you need to get a picture of that. Right. So the investigation and treatment for pancreatic cancer, we come back to Earth. So ultrasound scanning. Yeah, sure. Tell me.
And coffee is a known as a causative agent of pancreatic cancer, or it's not proven as such?
Coffee is supposed to be protective for the liver, but not so, not very good for the pancreas. Coffee is known to, prevent hepatic cancers, but pancreatic cancer they've found that caffeine actually increases the chance of pancreatic cancer. Okay, this is D Vita.
Thank you.
Okay. Ultrasound scanning, duplex scanning, no evidence of distant metastases. If you have distant metastases, ultrasound guided FNAC, palliation, surgery or endoprosthesis, or adjuvant therapy with chemotherapy, radiotherapy, and some people have even tried hormone therapy. And I'll tell you where they tried hormone therapy. Particularly solid pseudopapillary lesions have very high, or may have, sorry, I won't say will, may have very high estrogen receptors, which is why they often respond to tamoxifen. No evidence of distant metastases, and here do a contrast enhanced CT scan, a spiral CT, and we've showed you that, or an endoscopic ultrasound. If it's non-resectable, it goes into the other group. If it's resectable, if it's head, the patient can be jaundiced or not jaundiced. With jaundice, duodenal blockage. If there's duodenal blockage, you do an MRCP or a PTC and surgery. If there's no duodenal blockage, some would prefer doing an ERCP to get a biopsy if possible, or an endoscopic ultrasound, and then FNA, then proceed on for surgery. Right, staging. So this is the staging.
Sorry, sir, in the previous slide, sir.
Yeah.
Endoscopic ultrasound in the resectable cases also, do we need to do the endoscopic ultrasound as a compulsory investigation?
No, it's not. It's not really compulsory, but sometimes you have a doubt. Are we treating with pancreatitis? I have recently a patient who we have a doubt. Do we have pancreatitis, or is it, there's something, an element called a groove pancreatitis, where you actually have, it's very difficult to assess. Groove pancreatitis is a condition where, hang on, let me just show you. I'm trying to get my pen going. That is the C loop. And sometimes what happens is you land up with pancreatitis out here. Right bang. If that's the head of the pancreas, uncinate process, and that's the body, you unfortunately have pancreatitis at that area, and that mimics, it's severely in pain, and that mimics a tumor. So that is the sort of situation where you want an ultrasound scan, endoscopic ultrasound, and you might take an FNA to just be sure that you have a tumor and not a purely inflammatory condition.
Okay. Sir, another thing that I want to ask is if we have a resectable head mass,
yep,
do we need before the operation, proceeding before the operation, to take the US guided biopsy, sir?
It's not mandatory. It's not mandatory. If you have if your radiologist is sufficiently confident and tells you it is a tumor, you have to counsel the patient that this is 90% to 95% chance of there being a tumor. There's a 5% to 10% chance it might turn out to be benign. And then you proceed. Okay, but what you definitely need, and this is an older slide, you will realize this is an older slide. Before you proceed on to surgery, there's one other thing that you have to do, and that is a diagnostic staging laparoscopy. Okay, that is a must.
Thank you, sir.
Right. So staging, T staging, we go through the entire gamut of TIS, but T1 is a tumor less than 2 centimeters, 1A is 0.5 in its greatest dimension, T1B is 0.5 to 1 centimeters, and C is 1 to 2 centimeters in its greatest dimension. T2 is 2 to 4, T3 is more than 4, T4 is tumor involving the celiac axis, SMA, or the common hepatic artery. Nodes, N0 node regional lymph node metastases, N1 is metastasis in 1 to 3 lymph nodes, N2 is metastasis to 4 or more lymph nodes, and obviously M is no distant metastases and distant metastases. So the staging is thus: T1, the moment it becomes N0, M0 is a 1A, N1 makes it a 2B, N2 makes it a 3. For a T2, it starts off life as 1B with an N0, M0. The moment you have N1, it becomes 2B again, and T2, N2 becomes 3. T3 lesions, if it's N0, M0, it starts life as a 2A. With an N1, it becomes 2B again. So you have 3 sets of 2Bs. You can realize that T3N2 becomes a stage 3, and of course T4, NEN, NE, or M0 becomes a stage 3, right? So what is the prognosis? Median survival in months by the SEER database, and as of 8,900 and 9,000 patients almost. Stage 1A was 38 in months, 38, 1B was 24, 2A was 18, 2B was 17, and stage 3 was 14. So that's the duration of median survival in months. So
These are after surgery?
After surgery, yes, after surgery. So not a very good, very brilliant result, but there we are. And these are the prognostic factors. If the size of the tumor is less than 2 centimeters, it's better. 4 centimeters, starts getting worse. Lymph nodal involvement, surgical margins, extra pancreatic invasion to pseudocapsule of the gland, the histologic grade on the DNA content of the tumor, whether the patient has had neoadjuvant or adjuvant gemcitabine-based chemotherapy, and this was known as the CONCO trial, CONCO 001. It was done in France, the Charité Oncology trial, CONCO trial. Extensive microscopic evidence of intratumor perineural lymphatic invasion is very, very significant, and cigarette smoking. Guys, you will also listen to a lot of things that are done, and I have purposely have avoided that on the amount of lymph node to neutrophil ratio in the tumor. Be a bit careful. If you're going to quote that, read the paper, because it's not definite. So as a prognostic factor, which is why I've purposely avoided giving it to you. I'm not going to give you controversial things which are still under investigations. So what?
Sir, can you please show us the previous slide?
This one?
Just previous.
That one?
Sir, next.
We have a lot to cover, guys. That one?
No, sir. Just the previous slide of the prognostic factor. Yes, sir. This one.
Okay, there we are. Yeah. Cigarette smoking is a definite prognostic factor. So if your patient smokes, and thankfully my colleague there, he used to smoke about 40 cigarettes a day. He was very good, and he stopped smoking after his surgery. I'm not surprised. He had a radical nephrectomy and a Whipple's at the same sitting. Okay, can I go on? So borderline resectability. So this is something that you need to take a screenshot of. Solid tumor for the head of the pancreas and uncinate lesions, solid tumor contact with the SMA more than 180 degrees, with the celiac axis more than 180 degrees, with the first jejunal SMA branch, if it's in contact, it's borderline resectable. Unreconstructable superior mesenteric vein or the portal vein due to tumor involvement or inclusion can be either a tumor, embolus, or even a bland thrombus. Contact with the most proximal draining jejunal branch into the SMV. So these are the borderline resectable lesions of the head of the pancreas and the uncinate. Body and tail lesions, solid tumor, contact more than 180 degrees with the SMA or celiac axis. Solid tumor contact with the celiac axis and aortic involvement, and unreconstructable SMV or portal vein due to tumor involvement or occlusion can be due to tumor or bland thrombus again. For all sites, if you have a distant metastases, obviously it stops being a borderline, it becomes irresectable. And metastases to lymph nodes beyond the field of resection is also it shouldn't be a borderline resectable, it should be irresectable actually, it's distant metastases. So I have an issue with that, but head of the pancreas and body and tail lesions, I accept that. So unresectable disease is presence of metastasis in the liver, peritoneum, momentum, and any extra abdominal sites, encasement more than 1/2 of the vessel circumference, or occlusion or thrombus of the superior mesenteric artery, unreconstructible SMV or SMV, portal vein confluence or occlusion, and a direct involvement of the inferior vena cava or the aorta. See, guys, we can actually reconstruct a fair bit of the portal vein, unless if it's really extensive, then there's no point going in for a resection. The principle is that you can either put in a graft, or if you make sure that your splenic vein is tied off, which means, hang on, I better, I'm sorry, my pen isn't working very well. There's a bit of a lag when I do that. Hang on, let me see. I think I'll be able to. So basically, that's the portal vein. That's the splenic vein. So normally what happens is if you cut that, even if there's a fair bit of involvement and you need to take that away from that, you can either put in a graft. You put in a graft which, let me choose this color. You've put in a graft from there to there. Or if it's very small, you can do an end-to-end anastomosis, right? So, but if it's too huge and there's too much of thrombus all around, then it's not possible to reconstruct. It's unreconstructable. So that makes it. So the management way.
Ascites are unresectable condition. Ascites, if ascites happens.
Sorry, I didn't get your last. Can you come in once again?
If ascites is there, sir, in head of pancreas.
Yes. If ascites is there, not just ascites. Some people also do a peritoneal lavage, and if it's positive, some people say that if you've done a peritoneal lavage and that is positive, that is actually irresectable. But that has been queried. You know, we love to differ, but that has been queried. So basically what it is cancer of the head, jaundice, you do a pre-op drainage if, this is the accepted norm, if your bilirubin is more than 20 milligram per deciliter, or the patient have cholangitis, no question about it, you have to do that is an emergency, you have to drain the the biliary system. And also, if the patient comes in and there's going to be a delay of for about 2 weeks, it comes in with a bilirubin of 15 and you have a delay of around 2 weeks, you go in for a drainage. For whatever reason, you might want to assess the patient or increase the nutritional status. Whatever it is, if it's resectable, you go ahead and resect. If it's borderline resectable, you go in for a non-neoadjuvant therapy, which is a gemcitabine-based therapy. Some people would add a radiation to it and you reassess. And of course, if it's irresectable, then you go in for palliation. So what are the surgical? Subtotal stomach-preserving pancreatic duodenectomy, the usual Whipple's, a pylorus-preserving pancreatic duodenectomy, which is also Whipple, a vascular resection of reconstructible portal vein and superior mesenteric vein involvement. It's actually supposed to be a function of tumor location, not of tumor biology, which is why people still go ahead and do a resection of the portal vein. So it's purely that the lesion was there, perhaps an uncinate processed lesion which has involved the portal vein or the portal vein mesenteric, superior mesenteric vein junction. Minimally invasive has been tried. It's technically challenging but feasible, but does not add benefit of morbidity or mortality. So lymphadenectomy you try for 15. You take the suprapyloric, which is number 5, node station number 6, subpyloric. You take number 8, which is the nodes along the hepatic. You take the 12B, A, and C, which are nodes along the biliary channels. You take the 13, which is the retropancreatic nodes. It's divided into superior and inferior. I don't understand the significance, but you actually take that entire bit out if you're taking the head out. You take the 14V, which is the node along the superior mesenteric vein, and 14A ideally should be taken, which is the nodes to the right of the superior mesenteric artery. And you also take 17, which is the which are the nodes in front of the pancreas. So in addition to that, the Japanese, as usual, do extended resections. They would also take the celiac lymph node out and also the superior mesenteric lymph node out, and they would call it an extended lymphadenectomy. It hasn't proven to add any additional benefit, but you must try for at least 15 lymph nodes being taken out. Okay, so that's your lymphadenectomy. Head of the pancreas, guys, again, we are going into slightly recent advances territory. So please, guys, always remember this with only after people have, if they prod you to reach out here. The traditional approach, and you do an artery first approach. Approaches are as follows. You approach the SMA from the retroperitoneum, which is the posterior approach, the uncinate process, the medial uncinate process. Let me go to the next, it will make it easier. So the posterior approach is here. You go in right behind and you approach the superior mesenteric artery and start dissecting. This is for lesions which actually involve the portal vein out here. You go in for the uncinate approach, which is out here. You go in and approach the superior mesenteric artery first, and you use retractors to retract the superior mesenteric vein, and then having defined all that, then you go in for a resection out here. You might need to remove a portion of the vein together with your head of the pancreas. You can also do an infracolic, inferior infracolic approach. So come in through out here. You go in through also the left posterior approach, where you approach just lateral to the DJ flexure and you go on top and you approach out here. You can have a superior approach where you approach from here. Don't forget, guys, that the transverse mesocolon rises from there. So that's the transverse mesocolon rising, which is why the next is called supracolic, and it's called supracolic because of that. So obviously the colon is out here. So anything below is an infracolic, and on top is a supracolic. So you have a supracolic, which is there. So that makes it supracolic. So these are the 6 approaches to the superior mesenteric artery. And of course, for palliation, you can do an endoscopic palliation of putting in a stent. This patient has a double stent being put in, but you can also have a self-expanding metallic stent, or you can do a surgical bypass. It's usually called a triple bypass. Sometimes when you're doing a triple bypass, do remember, guys, that gallbladder is a poor substitute to do a bypass too, because don't forget that sometimes that actually goes in and drains fairly low out here. So it might get caught up in the malignant process. So the thing to do out here is do a cholecystectomy and do a bypass, a Roux-en-Y bypass, and you want to do a Roux-en-Y bypass to the either to the common hepatic duct out here or the common bile duct, and you bring it up out there, do a bypass out here, and that's anastomosis number 1. Anastomosis number 2 is out here where you've done a so that's your second anastomosis. And you anastomose this point to the stomach, so that because you anticipate for a duodenal blockage. So that is anastomosis 1, anastomosis 2, and anastomosis 3. So triple bypass. Right. Surgery for the body and tail, you do a distal pancreatectomy with or without splenectomy. And this was one of our SPNs, a young 17-year-old girl who came in, and we were convinced that the portal vein was slightly far away. We thought that this was the portal vein. And we thought that the portal vein was here, with a bit of pancreatic tissue in between. So we were not very clear. So we asked a radiologist to help us, and he certainly did. So that was we thought that there was a bit of pancreatic tissue bin. And when we did the patient was turned around, you can see that that's the lesion being lifted off the portal vein. So we could actually do a distal pancreatectomy without taking the spleen out. But this particular patient, who was 21-year-old, and we've had her about 3 weeks just before, they always come in pairs, we say. So this was a solid pseudopapillary lesion, and you can see that it's massively enlarged, and you can see that the portal vein, the splenic vein is stretched out. So there was no question about doing spleen preserving pancreatectomy. So we did a distal pancreatectomy with splenectomy. The lymphadenectomy for here is node station 8 along the common hepatic, node 11, which is along the splenic hilum, which is the 10, and also the nodes along the short gastrics 4SA. You also take the infracolic nodes, which are 18 out, and you also take the nodes on the left side of the superior mesenteric. So that's 14D. And of course, 14P, which is proximal. This is distal and this is proximal of 14. This is the superior mesenteric artery lymph nodes. And some people would actually take the 9 out here because it's very close. Actually, the body of the pancreas is quite close to the aorta and the celiac plexus. So you also take the celiac lymph nodes out. So some issues. This was a lesion, and you can see that that's the posterior part of the lesion. If you look at this, 1 is the liver, 2 is the caudate lobe. We know all that. 4 is the kidney, and this is actually transgressing into the gyrotous fascia. You can see that that is actually transgressing into the gyrotous fascia. As a result of which, if you have a very close look, you can see that it is actually going in out here. You see that? So the traditional way of doing a pancreatectomy, a distal pancreatectomy, is as follows. This is the route you would follow for a traditional distal pancreatectomy. But if you have a lesion which is very large, then you might actually choose a radical antegrade modular pancreatectomy. It's called a ramp procedure. And what is the ramp procedure? Ramp procedure is as follows. You have an anterior ramp, you take that, you go very close to that node, you go into the gyrotous fascia, go above this is the adrenal, the left adrenal and the left kidney, and you come in out here. So you transgress the gyrotous fascia and you keep that layer of fascia in between, so you're safe. Sometimes that lesion is actually penetrating out here. So that becomes a bit of a problem. And there you have something called a posterior ramp, and the posterior ramp is slightly more radical. So you, instead of doing that, you come in out here and you go in out here, take the left adrenal nodes out and you take it out this way. So it becomes a far more comprehensive surgery. So this is the ramp procedure. I told you we are going to go the whole hog today. Right. Now I've got another issue. That's the ramp procedure. You know that. Thanks to a young colleague of mine who presented me with this. This is a lesion of the distal pancreas. You can see that's the lesion of the distal pancreas. And of this, if you have a look out here, you'll notice that that is infiltration around this vessel. What is this vessel, do you think? What is this vessel?
SMA.
No, it's not the SMA, it's the celiac. So now what do? You give up? Well, I have a bit of a question now. So that's the celiac. What are these three vessels?
Splenic, common hepatic, and left gastric.
Okay, of these three, very good. Of these three, which is an end artery which doesn't have any collaterals?
Splenic, sir.
No. Splenic, you're going to remove it, isn't it? You're doing a distal pancreatectomy. It's not sacrificable. So you're going to take it out with the pancreas, isn't it? What about the left gastric? Left gastric supplies the stomach. You have the right gastric. You have, you have the short gastrics. You have the right gastric. You have the right gastroepiploic, and you have the left gastroepiploic. Of this, you're going to almost certainly going to sacrifice the left gastroepiploic and the short gastrics, because you're going to take the spleen out, isn't it? But that still leaves you with the right gastric and the right gastroepiploic. Okay? What about this? That has no collaterals. That goes to the liver. That goes to the liver. Let me just show you another. So if I show you a 3D picture, now if I can show you, see, that is your celiac. That is likely to be, they haven't been able, this is the splenic. Okay, that's the left gastric. That's the hepatic. Now think about that, guys. This is the gastroduodenal. And that gastroduodenal has a rich collateral. Usually it comes from the superior mesenteric. In this patient, it's come directly from the aorta. You have not one, but two supplies coming out from here. So if we were to take the entire celiac axis out, together with that, we're taking the left gastric out, we're taking the splenic out. If we leave the gastroduodenal intact and we take it out from here, if we leave the gastroduodenal, we even leave the blood supply for the stomach. The gastroduodenal usually gives the left gastroepiploic, isn't it? The left gastroepiploic comes from the gastroduodenal. So you have blood supply to the stomach as well. So if you were to take this part out, you have a flow coming in from down below. So that is a very, very advanced technique, which is called the modified Appleby procedure, which is done. So I'm going to show you that. So you have that blood supply coming up. Okay. So if you remove that entire bit, you've taken the celiac axis out. You've removed the entire celiac axis. You've taken the left out. You've taken the splenic vein out. You've removed till that point where the gastroduodenal come out, because if you've left the gastroduodenal, you also have blood supply to the stomach intact, and you have a rich collateral coming in from the superior mesenteric to help the liver. So that is called the modified Appleby procedures, guys. So that is, I wanted to end with that. Right. Any other questions? I told you we are going to go through the entire gamut of surgery. We're going to start off with basics and going to end up fairly advanced. So
can chronic pancreatitis lead to pancreatic cancer? And can pancreatic cancer present as a painful condition?
No, it cannot lead to pancreatic cancer, guys. And what's happened is some tumors present with chronic pancreatitis. I'll show you some slides, some pictures next class when we are doing cysts of the pancreas. Fairly recently, a patient of mine who had done a cholecystectomy on about 8 years ago came back with features of severe acute pancreatitis, and she actually had an IPMN of the uncinate process. So I'll show you plates on that. So sometimes tumors actually present with acute and chronic pancreatitis. But if you ask me whether chronic pancreatitis causes cancer, no, it doesn't.
So, but it can confuse in CT scan.
It can very much confuse. If you remember that we had chronic pancreatitis where you have a head mass. You remember there was a slide that I showed you that you have about 10 different modalities of assessing whether this is a carcinomatous lesion or a pure inflammatory lesion, because your treatment is going to be completely separate, isn't it? If you have a chronic pancreatitis with a head mass and you can't be sure it's not malignant, whether it's malignant or not, you have to go in for a Whipple's, isn't it?
Yes.
Whereas if you have a situation where you're confident that this is a benign condition, you may go in for a Partington-Rochelle procedure, a head coring procedure, and opening out the entire pancreatic duct by doing perhaps an Isbicki to take a wedge of tissue out. Okay. Right, guys, it was a huge topic. We managed to do it. I'm sorry we had a hiccup when we started off, but some of the my geo connection wasn't working. So good night. Take care, all of you.
Thank you.
The recording has stopped.
Thank you. Thank you, sir.
You're welcome. Bye.